Morning, good afternoon from wherever you're joining us from. Welcome to the PHTI ICHOM webinar, focusing on ensuring that digital health performance-based contracting are optimized using patient outcomes. We're so excited to be co-hosting today's webinar alongside Peterson Health Technology Institute, and I'm joined on screen by Meg Barron, Managing Director at PHTI. Meg, welcome.
Thank you.
We have a great webinar lineup for you today. And before I tell you a little bit more about what we're going to be talking about, I want to say welcome to the hundreds of people who registered from this webinar. Last I checked, from over 50 countries, representing industries and implementers of ICHOM's work. So we're very excited to welcome this dynamic group. We will be recording this webinar for posterity and open access afterwards. So with that, welcome, Meg, and let's get started.
Great. Well, welcome everyone, and thank you so much for having me, Jen and ICHOM. It's really great to be here. As Jen mentioned, I'm Meg Barron, Managing Director of Outreach and Engagement at the Peterson Health Technology Institute. For those not familiar with PHTI, we are an independent and self-funded nonprofit based in New York City. We're fully funded by the Peterson Center on Healthcare and the Peterson Foundation. And since PHTI's inception, which will be 3 years ago this year, our mission has really remained the same, which is to scale digital health solutions that work and that are worth it, with the end goal of helping to improve health outcomes and lower costs. And we do this by providing evidence-based, objective assessments of digital health solutions by category area, so that purchasers, and purchasers being employers, health plans, and health systems, can make as informed purchasing decisions as possible on behalf of their members and on behalf of their patients, and ultimately spend their budget on what works best. To date, we've completed 6 digital health assessments on topics ranging from digital diabetes management solutions to our latest on virtual GI solutions. I'll also note we've completed a number of thematic reports. Each year, we've been doing an annual State of Digital Health Purchasing survey and make the results freely available of that. We'll be doing that again come this summer, with the results available this fall. We've also released things like an employer purchaser guide for GLP-1 solutions. And again, all of these are available for free on our website at phti.org. One other thing I did want to quickly touch on is that for each of our assessments, we engage stakeholders in really all that we do. So as part of this, we interview patients with lived experiences for each of the clinical areas that we focus on. We also involve physicians with specialty in each of the areas and categories that we conduct assessments on. And then we also engage with digital health companies, where once we identify them as fitting the criteria for one of our assessments, we engage them to allow them to submit any additional or applicable evidence or data that goes through the same kind of ringing process as all the other data that we look at as part of each of our reports. A few other quick things. We convene a digital health collaborative, which is a group of leading healthcare and consumer organizations that share a commitment to raising the bar for evidence and value in digital health technology. And we have the pleasure of having ICHOM participate in the collaborative and extremely value their approach to ensuring that industry standards are patient-centered and optimized. So thank you to Jen and team on that. And then lastly, we also convene and lead a purchaser advisory council, which includes more than 45 direct decision makers from across leading health systems, health plans, and employers. And this is important because purchasers, and again, these direct decision makers from purchasers across the country, are really our target audience, so that we can help them make as informed purchasing decisions as possible, again, on behalf of their employees and patients. So really looking forward to the discussion today, and looking forward to sharing more about the insights we've gained from both our Purchaser Advisory Council and nationwide purchasers, including the need to ensure that contracts with digital health vendors and partners are focused on outcomes, not just engagement metrics, so that the best results possible can happen for patients nationwide. So with that, Jen, I'll turn it back to you.
Meg, thanks for that really terrific overview of PHTI. And ICHOM is super pleased to be partnering with you. We're really grateful for the reference and tie back to our work in your work, which is really the hallmark of partnership. I want to take just a moment to level set a little bit for those of you that may not know ICHOM, very briefly, just to give you a background. And I think there's a next slide. So, like PHTI, we are a US-based nonprofit, but unlike PHTI, we actually serve and work with a global audience of healthcare professionals, industry, clinical and research entities, patient groups all around the world who hew to the belief that value is really about outcomes that are important to patients. So we represent 30,000 some odd individuals in those spaces that I just mentioned who are actively working in their work, whether it's frontline clinical service or industry innovation or patient advocacy to champion outcomes that are important to patients. Our primary mission when we were created in 2012 was as a nonprofit that focused first and foremost on creating standards for what we should be measuring and how we know whether it is truly measuring the outcomes that are important to patients, not only clinical metrics, but also metrics of life quality, functioning, pain, mental health, all of the things that help patients not only improve in their health condition, but also get back to life. And so that's really the core work of what we do. And we see our organization as both the catalyst and a facilitator for those that want to do this work, with the core being our measurement sets. Go ahead to the next slide. And so I just want to start this whole conversation by premising that when ICHOM and our community talks about value, when we talked about what value-based healthcare really means, we fundamentally come at it from the equation that it is first and foremost about achieving health outcomes that are important to patients. And the equation is those outcomes divided by the resources that it takes to achieve them. This is a slightly different mindset, especially in the United States market, where we tend to focus more on measuring process and outcomes that are related to steps and services and activities that are delivered. And what we are talking about is moving towards measuring not only survival, not only the results of clinical intervention, but also things around independence, about pain management, about mental health, about functioning and mobility and being able to get back to work and activities that are important to patients. So this is not a diametric opposite to typical conversations about measurement and outcomes and how we drive better systems of care and payment, but it is a different angle, if you will, to where we start the conversation. So I think it was really important for me to frame that as we enter this conversation about, okay, how everybody is interested in getting better bang for the buck, as we say here, but better impact for whatever currency you're using, whatever resource that you're putting into healthcare. We all want to see that we get the most for that resource spend. How do we do that in a purchasing and contracting way that optimizes patient outcomes? That is today's conversation. And I'm really excited to welcome a list of really terrific speakers. I will introduce our panel more explicitly in just a moment, but you're going to hear from perspectives that include ICHOM, also include the employer, purchaser, the industry and contracting end of things, and most importantly, the patient perspective. So we're looking forward to this conversation. And what I would like to do next is welcome my colleague, Grace Jennings, who will do a bit of a level set about ICHOM's work in practice and why we think that it is positioned really well to support ongoing focus on performance contracting. So with that, I welcome Grace to the stage.
Thanks so much, Jen. And thank you so much for having me here today. I really appreciate it. And what a great chance to speak to people from all over the world. So as Jen has just said, the whole point about value-based healthcare is to try and create a new framework for health that isn't just about buying inputs, but achieving outcomes that truly matter to patients. And ICHOM, which stands for the International Consortium for Health Outcome Measurements, provides that framework for measuring what really matters to patients. So you'll see here on screen what we call our wheel for the obesity set. And you can see that there's a whole bunch of different domains that people find very important for people living with obesity. And we come to this understanding through a complex methodology involving a working group with both clinicians and people with lived experience, our patient representatives. And this is a holistic vision of what really matters to patients with the condition of interest. And we use these sets of measures in order to, encourage buying those resources that can deliver this type of outcome. And it's this holistic vision which underpins the idea behind value-based healthcare, is the value, the numerator over which the denominator, the resources used, can be achieved. Next slide, please. So you'll see here that we have people who use our sets all over the world. And that's what the map here is. It shows people implementing our sets, both in terms of people who just use the sets from day-to-day practice, as well as those who've been through our accreditation process. We have sets that cover approximately 60% of the global burden of disease. And we have, just as of last week, launched our 48th set, the kidney stone set. And we are currently developing 3 new sets: liver disease, bladder cancer, and spinal muscular atrophy. So you can see it runs the entire gamut of clinical conditions. And that's because we feel that it's really important to cover the entire spectrum of who has this, who is affected by health conditions. And we have this global perspective very deliberately, and we make sure that we bring in people from all sorts of different healthcare settings to provide input into our working group process so that we can truly call these a global set. Next slide, please. So the things that go into our sets, it is a multifaceted, set of parameters. But these are the 5 key elements of our sets that we define through this working group process. So we have our case mix variables, which you might think of as sort of baseline characteristics. And these are the factors that influence outcomes, but aren't actually an outcome in and of themselves. You can't necessarily control them through treatments. So in a more sort of obvious way, these are sort of demographic information. In this case, in the lung cancer set, these are sort of PD-L1 expressions, other biomarkers. In other conditions, these might be things like, starting, age, sex, ethnicity, etc. So these are all the things that are fixed and that you can use to adjust risk when you're looking across populations. The second thing that we define in our sets are outcome measures. And these are the clinical and patient-reported outcome measures that are really important to patients living with the condition. So like I say, these are both the clinical conditions, the clinical outcomes. So here it could be sort of things like size of tumor, overall survival. In other sets, it might be something like HbA1c, so very clinical measures. But then it's also the measures of health-related quality of life. These can be both generic instruments, such as PROMIS or EQ5D, as well as more disease-specific outcomes. So the whole point here is to get that really holistic understanding of what is important to people living with the condition. Then we think about what sources these data tend to come from, and often they come from an electronic source. So for example, from a clinical reported outcome, if these have been entered into a electronic system, but they can also come directly from the patient, hence patient-reported outcomes. And we collect them using these validated instruments that we specify in our sets. So again, these are the specific instruments, whether these are specific blood tests or indeed specific health-related quality of life outcome measures. And then finally, our sets specify at what points these should be collected. And the idea here is to try and standardize the measurements of these so that they can be compared, so that you can do, for example, you can do thinking about it longitudinally, that we collect enough data for it to be meaningful over time, but not so much there's a huge burden on the patients. So that's the sort of whistle-stop tour of what the sets look like. And the next slide, please, gives you an example of the diabetes set. So again, you have the circle, which has the domains of interest. So things like patient-reported outcomes, activity levels, chronic complications. And then we think through what is it that we are measuring within them. So we could be patient-reported outcomes, and you can see here that there are several that are collected. So PROMIS Global Health, as well as other more specific diabetes, distress, and obstructive sleep apnea. So again, from the generic to the very specific. We also recommend the collection of specified clinical reported outcomes, so CROMs. So for example, glycemic control is very key for diabetes, as well as other acute and chronic complications, as well as I mentioned before, the case mix variables, so socio-demographic factors, lifestyle and social factors, and treatment factors. So this gives you an idea of the sort of range of data that we recommend to capture when you employ our ICHOM sets, because these data give you an idea of not only what the outcomes are, but who is achieving these outcomes, what treatments have gone into it, and therefore what you might be able to modify in clinical practice. Next slide, please. And to show you a couple of ways in which these sets have been used in terms of contracting very specifically, the first was an early engagement with the Bedfordshire at the time CCG, so Clinical Commissioning Group, although the NHS doesn't use that terminology now. And the idea here was to think through how this Bedfordshire CCG could use the ICHOM set to commission high quality care. And what they did was they entered into partnership with a group called Circle, and they launched this musculoskeletal contract with Circle Partnership. And the idea here was to measure the low back pain set alongside things like EQ5D to deliver the best value care through linking reimbursement to collection and ideally improvement of these outcomes. The initial 5-year contract was for £120 million, and they showed that there was a projected £600,000 financial benefit as of 2017, with a £4 million projected 5-year benefit. So for one specific condition in one CCG, this is actually a fairly significant amount of money. So you can see here that actually using the set we were able to help them to identify a route to creating value for patients through the mechanism of the contracting, rather than just looking at the data and seeing whether or not patients were improved. It was actually tied to reimbursement using things like PROs. Next slide, please. And a similar example where there was a very specific and explicit commitment to value-based healthcare is a 10-year value-based contract in the Netherlands. This was more tied more specifically to HbA1c levels for diabetes. But again, the whole point was to try and link outcomes to reimbursement, with a later interest in also including PROs from 2024 onwards. And the idea here is to figure out which patients need the sort of most intensive care at which points and how these outcomes can be improved. And they did this through quite a sophisticated mechanism where they broke people down into age categories as well as sort of risk categories. And they were able to identify how to help the people, particularly in that sort of middle level risk, reduce the risk down to a lower level. So you can see here that 55% of pediatric patients achieved the target goal of an HbA1c of less than 7.5%. And that went up by almost 10%, the people who were able to achieve this level. And similarly, the adult patients were able to achieve a 62% control rate versus the 39% national average in 2023. And the perspective here was of the holistic vision of diabetes care. So what they wanted to achieve was not just a fixation on a specific number, but also the different services it takes in order to deliver it. So they had all sorts of different teams in place, everything from nutrition to psychological coaching to clinicians, all within one area, well, within one clinical setting, so that people could access the support they truly needed rather than being siloed into specific service areas. And overall, what they found was that by creating this more holistic vision of care, they were in fact able to reduce costs over the entire treatment pathway. And I think that's a real vindication of this approach, although they might have had slightly higher upfront costs when they were putting this into practice. It was possible to demonstrate that it in fact lowered the cost of care over the entire treatment pathway. Next slide, please. So there's a plethora of options about where value-based care and specifically standardized outcomes could go next. So in the shorter term, we might be looking at figuring out these ways of creating KPI frameworks for vendors and providers. So what are you going to measure and what is that going to do for you? So what kind of reimbursement could be tied to it? Can we do this sort of comparable evaluation of digital health solutions? If everybody's measuring the same thing, it's much easier to understand what effect things are having, especially when you consider the idea of these case mix variables so that you can take risk into account. You can think through the different contracting and procurement models, and again, reducing the fragmentation of outcomes definitions will allow you to really hone in on what's important to patients and hone in on how those outcomes can be best achieved. In the slightly longer term, we could be looking at outcomes driven reimbursement models, thinking about linking bundled payment contracts to outcomes, thinking through perhaps even reference benchmarks for what does good look like, and improving cost effectiveness for service providers and for service delivery, as well as, again, enabling these transparent comparisons across systems. And then finally, in the long term, it would be amazing to get to a point where we could do cross-country benchmarking, really understanding what good practice looks like for a specific type of person, and then being able to use that learning across different global boundaries. We might be able to think through ways in which multinational employers could look at population health comparisons, as well as global reference points for value-based purchasing. So finally, thinking through how we could do the entire global ecosystem of value-based healthcare using standardized outcomes. Thank you very much.
Grace, thank you so much for that wonderful overview. I want to note that there are some questions showing up in Q&A. We will do our best to address them as we continue our conversation in due course. We also received a number of very technical questions in the lead up to the webinar, which we are glad to see. I will say that one of the things ICHOM will endeavor to do is to put an FAQ together to share with all attendees of the webinar to answer those questions, anything that we don't get into during this conversation. But I'd like to, I see them already showing up, the panelists that we have invited today, and let me just briefly introduce them before we get off and running to really talk about our individual perspectives. So you've already heard from Meg, but Meg is the managing director at PHTI and certainly brings perspective, as she shared, with their journey in looking at performance-based contracting for digital health solutions. We're also joined by Jenny Chi, who is the vice president of global benefits for PepsiCo. So she's bringing the pragmatic, what is it that purchasers need? How are they trying to navigate a deluge of data, and what's the role and the opportunity for patient outcomes as being a resource and a driver for their decision making. We are also joined by Gabriela Prada, who is the senior director of global health systems policy at Medtronic, but has deep and international experience in performance-based contracting. And I'm very much looking forward to her wisdom and examples, because one thing I think we can start off by saying is that value-based contracting based on outcomes is actually, it's a topic on the tip of all of our tongues, but it's not new. It's being done in a lot of places. I think what we're talking about is how do we elevate it? How do we ground it in the data that's most important to patients? Excuse me. And then last but not least, we always ground our work at ICHOM in the perspective of lived experience. And I'm really pleased to welcome my colleague, Jessica Jackson from Mental Health America, which is an advocacy group here in the United States. But she also brings a deep expertise, both clinically and from working in the technology and innovation spaces. So really glad to have all of you ladies, dare I say ladies, conversation about this important topic. And so I'll kick off the panel by Meg, welcoming you to kind of add to your opening remarks, and really talking about why, from PHTI's perspective, you see such an opportunity to working toward more standardized benchmarks tied to patient outcomes. Where do you see the opportunities for us to really escalate the alignment between outcomes measurement and performance-based contracting? So
Yeah,
lead off.
absolutely. And, thanks again, Jen and Grace. And let me just give one more kudos that, the work that you do gets leveraged and should get leveraged as widespread as possible. I know for the assessment reports that we put out, we always ensure to make sure that the ICHOM standards that do exist get rooted into the recommendations and really work and evaluations that we do for each category area that we assess. So thanks again for that. Related to performance-based contracts, so I mentioned that our mission is to help purchasers make as informed purchasing decisions as possible on behalf of their members, their patients. And as part of this work, the past few years, purchasers kept coming to us with similar questions and really frustrations, such as, how are we knowing that we're getting what we're supposed to be paying for as it relates to all these different contracts we have with digital health solutions, vendors, et cetera. And once we know what good should look like, either from PHTI assessments or from ICHOM standards or even their own due diligence, how do we best translate that to our contracts to, again, ensure that they're getting optimized as best as possible? And we were also consistently hearing a desire to move beyond what historically has been more clawback arrangements for performance guarantees that often end up getting quite contentious and can be a time drain for everyone involved, as well as some pretty loud and clear consensus that, per member, per month arrangements that largely are often engagement focused, just no longer are cutting it moving forward. So what's part two, or how do we evolve from that? And these questions and needs were really what were validated, I should say, in our most recent State of Digital Health Purchasing survey that we conducted. That, again, we field to nationwide purchasers across the US, at least at this point in time. And what that survey reiterated was that many purchasers struggle to hold vendors accountable. And even when and if they have actuary support within their teams, most purchasers still aren't satisfied with their current contract and see opportunities for improvement. And ultimately, employers, and I'm sure you'll hear from Jenny and others on the line here, want to ensure that there are guarantees for the outcomes that they are agreeing to, and they want to be able to see that through. So for these reasons, we set out more than a year ago to address this problem. And to build this work, we engaged more than 50 stakeholders across purchasers, across digital health vendors. We also included some groups like employment brokers and consultants and data warehouse partners. And based on the interviews we conducted and needs that we heard, we created a few things. And again, all of these are freely available at phti.org. But the first is a playbook that really synthesizes the insights and best practices we collected. And in this, we outlined 7 key elements that purchasers and digital health vendors routinely navigate when attempting to design optimized performance-based contracts. So this includes things like how to design an optimal payment model, how to create standardized measures and outcomes, again, building on the great work that ICHOM has put out, and then how to navigate really a range of operational issues like data sharing or administrative terms. And then in addition to our playbook, we developed interactive, which really are more condition-specific toolkits that help translate the findings from our assessment reports into actionable next steps. And so far, we've created 4 toolkits. So one for digital diabetes management solutions, one for virtual musculoskeletal solutions, one for virtual hypertension solutions, and one for depression and anxiety virtual solutions. And moving forward, we plan to create these contracting toolkits for every assessment area that we put out. And I'll just say that these toolkits are really designed to be as much of a how-to guide with really practical recommendations that translate over the findings from our reports into ways that they can further improve on, or again, optimize the contracts that they're entering into with digital health vendors across the country. Let me stop there, but again, a high level overview of both the playbook, performance-based contracting playbook, and then really pragmatic, or we hope to be pragmatic toolkits that we've put out so far.
Thanks for that, Meg, that overview. Actually, you can take the slides down, Anya. So let me turn to Jenny. Jenny, you're one of the people that in every conversation, you're at the heart of this, right? You're making decisions every day about what you're purchasing on behalf of the lives that you have responsibility for. So talk to me a little bit about why this conversation is so vital from your perspective. What does it change for you potentially? And as you think about what you're trying to do in your daily life, what's going to be even a small step forward that's going to help you do your job better? And, I think this is just an opportunity for you to frame kind of where you're coming from as a purchaser.
Yeah, thank you. Thank you, Jennifer, and to ICHOM and PHTI for allowing me to participate on this panel. This is a very passionate topic for me. So I would say that, given everything that's going on in the market, employers are definitely struggling with justifying how much they're spending for the programs that they have. And depending on the employer, you're looking at it from different perspectives, right? Some employers might have the flexibility to say, as long as it helps one person, it doesn't matter what I spend. And we're not, or you might be closer to our end, which is we're really looking at ROI and what is this program bringing with regards to outcomes for our population, to our people. And so what's really vital with regard to how we purchase is that we understand what we're purchasing, and that what we purchase performs to what we expected to purchase. So for us, PGs and outcomes are very important. We also want to look at the employee holistically. So that notion of data and having the right data across all of our platforms is even more important, because if I have a program that has part of the data and programs that don't have any data, or programs that do have data, I never get to a holistic picture. So one of our requirements was, you guys all have to provide this amount of data. And if you can't do it, then you can't play, because I'm only as strong as my weakest data provider. So if not everybody's there, I'm never going to get there. And it was interesting to see the vendors that could step up to that and the vendors that couldn't. What we're really hoping to change with regards to having these conversations and hopefully getting other employers into really understanding what they're purchasing and what it means, is that then there can be more of a push from the employer side to really help design these programs that work better for the things that we're paying for, as opposed to paying for programs that we think will solve part of the problem, but not get us all the way there, because we either don't have enough information or tools to be able to get there. And one of the things that we put in after we put in PGs was definitely an audit, right? Sometimes you think you know what you are getting based on the performance and the measures. And when you get it, it doesn't quite make sense, because maybe what you're seeing in your employee population is slightly different than the data that you've been provided. And so how do you get to the disconnect? Where is the disconnect and how do you find it? So we started putting audits into vendors so that we were understanding what it is that we were measuring, and helping to understand, well, is it a tweak in the program that needs to happen? Or is it something else? Or is it something else that's just not happening, that should be happening, that maybe not captured in any of the PGs? That was really important. Additionally, the move from a PEPM into a utilization format was important for us, because you can purchase on PEPM, and I think we're at our size of, almost 250,000 lives. People love the PEPM model just because of how many people we have. But when I think about the population actually using it, it doesn't do us any good to pay PEPM regardless of what the pricing is. So we base our pricing on utilization, just to make sure that, is at least the employee satisfied. However you want to measure performance or utilization, what's happening. With regards to daily life, I think that all we're trying to do is bring the best care to our employees. And I have a huge frontline population where, for many of them, they're in care deserts. And so it's even more important for me to make sure that we're getting the care that they need, particularly virtually, because the providers just aren't there, or maybe not as available for them in person. And so that's where these digital health solutions become even more important, because I need to be able to ascertain that we can impact the lives of those people who aren't able to get care, and that we're helping them be able to thrive as opposed to just getting back to work. So that was a mouthful, and I could talk about this for days, but I'll just stop there so that the other panelists will have a chance to comment as well.
It's terrific. And I know this is a passion piece for you, and it's just so heartening to hear from the purchaser, and especially a large multinational employer like Pepsi, the importance of it's not just access to care, it's also the quality of care that they're accessing. And those two things need to come together. I think we spend a lot of time measuring one or the other. And I think this conversation really is about how do we bring it together and utilize all the tools we have in our basket to incentivize and kind of align those incentives. So let's turn a little bit to Gabriela. Gabriela, you have enormous and international experience in what does value-based contracting look like in real time, in real life. And I was hoping that you could reflect a little bit on what you've seen over the course of the work that you've done, and what you see changing. Do you see a change in the conversation? Do you see a change in the appetite for bringing patient-centered outcomes into this conversation?
Hi, Jennifer, and thank you again for inviting me to this great conversation. This is also another topic that I feel absolutely passionate about. I've been working in this field for many, many years. And, probably as a physician, I like for patients to do better and have access to better outcomes. And to me, this is a tremendous tool to help improve outcomes and improve it significantly faster. I mean, one of the key differences between, the contracting side and value-based healthcare in overall is that I find that the contracting, when you think about value-based healthcare in terms of a contract, in terms of a procurement, it makes it a lot more tangible for people to understand. The steps are more clear. When you start thinking about value-based healthcare, it implies a transformation of the healthcare system that could be really overwhelming for people. You don't know where to start, right? It's so massive. Like, you need to start aligning the funding. They're providing the right incentives. They have the right mix of providers. How do we go and partner with other people? What are the collaborative models that I could explore? So it could be really overwhelming. And to me, that's the real value of the value-based procurement or thinking on the contracting side, because it makes it much more smaller, right? You have a contract objective, a particular objective. You have a group of people that are invested and involved in the design of that project. And then generally, everybody who participates is invested in the best, potential outcome coming from that contract. So one of the things that I have seen which has been really positive, is a change in the vendor, in the purchaser and the vendor relationship. Generally, when you manage a regular contract, you have a kind of an opposing view, right? So the purchaser becomes like the project manager, and it's my role to make sure that you are fulfilling all the boxes, and you go through your long checklist. What I've seen in value-based contracts is more like a partnership, because you're on this together, right? And it's very important for both the purchaser and the vendor to come and realize the outcome. So it really changes the language, it changes the relationship, and provides much more opportunities to actually be successful. And this is only at the beginning. So you might start with a small idea, and then with time, and as you experience and you get more proficient at some of these models, then the ideas continue growing, right? And this is where you can expand. Well, we did it for this. Now, what did we learn, right? So can we use it in some other projects? Can we grow the population that we chose? Can we expand it to our clinical programs? And this is where the magic really, really happens. I think that a lot of vendors, I mean, and Jenny made a comment, she said it was interesting about what vendors were ready, to provide the solution that they were looking for, and what vendors were not ready, and what type of responses. This has been very typical. I have seen these many times. And actually, when you think about public healthcare systems, where the governments always say, well, I don't know if I can ask this, if it's a fair ask, to the vendors. Not all the vendors are ready to provide some of these. And my answer to that was, well, if you never ask, you will never get it, right? So this is part of the change that has to happen within the system. You need to start asking other type of questions. And only by asking these questions, you can really unleash the potential, range of solutions. And this is where the real innovation come from. I was delighted to see that the diabetes example was presented. So a little bit about Medtronic. So we're a large medical technology company. Medtronic has been in the value-based healthcare and value-based contracting for many, many years. And we have executed similar projects to diabetes in many countries. And I can say, the results that you saw in the Netherlands have been replicated in other countries. So the same come true in the Netherlands, the same happened in a few other countries, and it's still happening today. So that really, speaks very highly of the model, right? The model really works. The interesting question is also, the cost of this investment. So there was a comment made that, yes, it saves time over the longer term, but then you might need some initial higher costs in terms of rebalancing the team and making sure that you have the right IT platform and the digital solutions that you need to run a program like this. One of the challenges in healthcare is that a lot of people who make the decisions today are not necessarily going to stay there in 2 years, in 3 or 4 years. So yes, it is cheaper in the longer term, but actually a lot of the decisions within healthcare are made short term and medium term. And again, this is one of the opportunities which I think from a contracting perspective, it really helps to focus the value-based healthcare movement into contracts, because it gives you a very fair timeline, something that you can live with, right? So there are many different outcomes that you can track that may take, a long time. Like if we think of solutions like bariatric surgery, for example, you don't necessarily get to see all the different outcomes that you are hoping to get within 3 months, right? Sometimes these patient care pathways take years. And I've seen contracts up to 2 years that provides the whole range from pre-screening, working with the patients, making sure that the eligible patient population is the right one, going through surgery, and then going after the surgery and making sure that these patients continue on the right pathway for many months after the surgery. But there are always ways to identify outcomes to make sure that we continue in the right track. And it's not about selecting 100, outcome indicators, because that's not really the point here. But what are the one or two sentinel indicators, real patient outcomes that can tell you whether this contract is going in the right direction or not? And I think in order to choose some of these, it's super important to have the input from the providers and from the patients. What is value for me, right? So, and without having that agreement at the beginning on what value means, then these contracts become very vague, and it will be very hard to know 5 years after that contract whether you've been successful or not. So just working on I really like to always engineer back when I think about how to put these contracts together. Is really a lot of the time, I would say 70% of the time and the effort has to be in identifying what value means, what are the key performance indicators, who are the right actors to tell us this, and then how we can work and incorporate this into potential contracts. This is where the chunk of the time and the effort will go. And I can expand in a lot more things, but I just want to just keep it brief now, and maybe we'll come back to some of these topics.
Thanks, Gabriela. And Jessica, I think you bring both the clinical background and the patient advocacy background to this. And Gabriela just said that defining the outcomes that are important really starts with that team, right? That the people that are making those shared decisions about what are the interventions, what are the pathways for moving or helping an individual into recovery. I would love for you to reflect on what is the risk of not embedding patient important outcomes in this conversation as we're in a very important moment in time, I think, in the United States from a policy perspective. But I would love for you to reflect on that and also your experience in championing the importance of results of care that are important to people living with mental health conditions. Do you see a change happening in the conversation with digital health organizations, with employers, with others in this ecosystem, and a bigger receptivity to patient outcomes? Or what's your take on where we are today?
Yeah, big questions. And similar to Gabriela and Jenny, I'm very happy to be here. And it's a topic that I'm passionate about. And I think, listening to something Jenny said earlier about, the data, that you're only as good as the data that you have. And that is important, but what is also important is how we interpret the data. So I am a licensed psychologist working at Mental Health America. And so thinking about that intersection, even as a provider, when I am working with someone, we need to have two different or more than two, but multiple data points. So for example, if someone uses something like a PHQ-9, that tells me about your symptoms, less about your functioning. So if I'm working with a patient and they're saying, maybe they score 17 on the PHQ-9, but they're telling me, I go to work every day, I am feeling productive, I am, I'm a parent, all of my kids are doing well, I'm making everything, there's an inconsistency there, right? Because sometimes when people have been in distress for a very long time, they figured out ways to cope. Right. And so if I'm just looking at the clinical data, I would say they're not really improving, they're not doing well, but they're speaking up and saying, I am doing well for the situation I'm in. I would like to be better. Right. And I think that is one of the things that is important is how do we take multiple types of data, especially when you're thinking about contracting. It's what is important for me to be able to track clinical symptoms, but then what does that actually mean? I think another great example is thinking about things like satisfaction and therapeutic alliance. There's plenty of research and data that shows that therapeutic alliance strengthens the intervention. So somebody who feels connected to their mental health provider will have better outcomes. And there's decades of data on that. The risk when we do not include data like that in value-based contracting or, when people are looking at engagement metrics is that some people, for example, want data, they get data quarterly in mental health, and I think it's important to add the nuance that mental health is a different therapeutic area than others. When we talk about value-based, it's a little bit more difficult because most of our outcomes currently are patient-reported. There's innovation happening to change that, but right now, most of it is patient-reported outcomes. But for the example, so think about someone who, Jenny, I'm just going to use you as an example to help make it real. Let's say Jenny's saying, I want reports every quarter on outcomes. Well, for somebody in mental health who's only seeing someone every other week, that's only about 6 to 8 sessions. So how much change are you going to see in that time? And if you're looking just at the outcomes, it may look like folks are not getting better. But if you were to add a measure like therapeutic alliance, then you have information that says, but they have a strong therapeutic alliance, which will lead to better outcomes as time goes on. It gives you more data versus they're just not getting better. It may be that there hasn't been enough time. So when you have additional outcomes that are important to the patient, the satisfaction therapeutic alliance and the clinical outcomes, you get a better picture to be able to support folks. I do think that, the other risk in this is when folks are looking at data, we also don't look at stratified outcomes. What is working best for which populations? People use the term engagement for everybody. Well, what does that mean? If I have, mild to moderate anxiety and I'm scoring maybe a 6 on the GAD-7, is your intervention for somebody with mild to moderate? Is it for somebody with a higher acuity who's at maybe, a 12 or 13? And so when we do stratified outcomes, it helps us to see, is the intervention, the digital intervention, working differently for different populations, and that helps us to level set our expectations for outcomes. I'm expecting greater change in this group than this group because of how the intervention works at different levels of acuity. And I think that is really important. And when you talk with patients, they're saying the same thing, like, this is what matters to me. It doesn't matter that I only move 2 points on this scale. I actually am feeling better, and that's showing up in how I show up at work, for example, or that's showing up and I have more connection with my family. So it may only show the 2 points, but that's not the full picture. And so I think the risk is when we're not measuring the data accurately, or even the way we're interpreting it, that we run the risk of saying things aren't working that actually are working. And we also will miss populations. So I think that's the last piece, is one of the things I think everyone can agree on is how we define engagement. And we have to be very careful, especially if we're focused on quality of care for our patients, that we specifically define engagement. It is not just I opened the app, I downloaded the app, or I logged in. What is actually happening? And often people use that word engagement very broadly. And I think in contracting, you have to be very clear what you're looking for. Is it that they attended a session? Is it that they completed an intervention? Like, what exactly is engagement, so that you make sure your measures are tracking that outcome?
Love it. First of all, you emphasize things that are very top of mind. I know we've talked at the PHTI ICHOM level about selection of data, timing of data, what you're using it for, and the most important, what you said about stratification and really understanding which population, subpopulation does your outcome metrics actually have meaning. And I think right now in this conversation, dare I say, we're in a homogenizing mode where we try to lump everything together under an umbrella term. And I think you said it perfectly, Jessica. So we're going to open up some questions from the audience. So if you're in the audience and you have some burning question, put it in the Q&A now so I see it. But before we do that, let me just cut to the chase. Why is this so hard? We everything that all of you said is pointing at absolute positive opportunity and a need. So where, from your perspective, what's the holdback? What's the inertia? What's the point of friction that's keeping us from moving this into implementation? Because I'm an implementation girl. Who wants to start with that?
I'm happy to start. One, because
Okay.
I'm internally clapping inside after Jessica, Jenny, and Gabriela's comments. But two, just to go back to one thing that Jessica mentioned around the right patient population getting access to the right solution at the right time is massive. And, that is one thing that we attempt to take a lot of time on for the PHTI assessments that we put out. Ultimately, our goal is to help answer 3 key questions on behalf of purchasers and patients across the country, which is, does this solution, category of solutions, clinically work based on the available outcomes data and based on a systematic literature review we do of all the published literature? But then a secondary piece of that is, for whom do they work best, to Jessica's point, because they're not usually one size fits all. And there usually is some triaging of sorts that can be thought through that then can help to inform the last key question of, is it worth it? Like, in comparison to usual care, when we're thinking about adding on another digital health solution that potentially could add cost versus lower cost, again, is it worth it? And really the nirvana is finding solutions, which we have, that both clinically work as good as, if not better than usual care at times, and that also can be used to expand access and ultimately lower costs. And that, at the end of the day, is what we look to surface in each of our reports. And then, Jen, just to touch on your question of what has been the hurdles, I mean, I'll let the specific purchasers in the room speak to this, but from what we anecdotally hear, both from our purchaser advisory council members and from the surveying that we do and just being out speaking on this topic quite often, is that really the market has matured like as well. I formerly was vice president of digital health and innovation at the American Medical Association, and I was with them for over a decade, and including during the pandemic period where everyone, it felt like, was starting to further experiment with different digital health solutions and especially telehealth, which was great. But I think that there was a lot of experimentation happening, and now everyone's taking, a slightly more zoomed out view and also putting a magnifying glass to what does success look like for me? And then again, how do I make sure that that's translated appropriately in contractual terms to the outcomes I expect to see? And that's a two-way street conversation. And these are really relationships that you're entering into with different partners. And I think it was either Jenny or maybe someone else had mentioned, that the end goal, no one really wants to contract necessarily with 10 different solution vendors for 10 different problems that they have. In a perfect world, there's also vendors that are understanding the kind of bigger scope of problem set that you as purchasers or you, right, from a policy standpoint are looking to represent on behalf of patients, and starting to put the puzzle pieces together for that. And the same can be said from a contractual standpoint. And this is where I have optimism, because there were a number of vendors that we spoke with as part of this performance-based contracting effort, and a number of vendors, and I would say especially those that have done well, like in our PHTI assessment reports, that were quick to raise their hand and say, we could make this work. We could make these tweaks definitely happen, or we're willing to, again, have flexibility on this in our contract terms. And then the two-way street back to engagement of course, on the other side of the fence, they're looking for certain specifics to be met for the number of times that something gets communicated to your members or employees, right? Or things of that nature. And all of that we've attempted to outline as best as possible in those performance-based contracting toolkits that we've put out. So again, just kudos to the work that you're doing. And Jen, I'll turn it back to you.
Anybody else want to on what are some of the hurdles that you're experiencing, or what is the friction point we have to get past for this to really take off like wildfire? Or do you feel that we are doing it's on a natural course of evolution? I think that's kind of the précis of what Meg just said.
Yeah, I think one of the things I would advise, so implementation is also thinking about, do you have something like a patient advisory council? How are you tracking that this is actually what folks are struggling with and want support with? The analogy I always use, it's like a house, right? If you don't have a home and you need one and someone just gives you one for free, you walk in and you say, this has a lot of stairs. I can't take stairs. And, this only has 2 bedrooms and I have 10 people in my family. Like, the house doesn't fit. How likely are you to use it as much as you could? You could make it work, but it's not going to be ideal, and that's going to show up, right? And so I'm like, we're always building houses that don't fit folks because we're not asking them. So asking the folks. So as the employer, do you have a patient advisory council, folks who can say, here's what is really meaningful for us? I also think thinking about hybrid contracts. Are we not just measuring engagement, but are we also measuring other things, right? Are we measuring almost what I would call like the inverse? Instead of saying how much better folks are getting, are we measuring things like we have less folks in crisis? Right? That looks different than they're thriving, but it's less folks in crisis. Are we measuring, and some people might call those almost like failure measures, but thinking about how many folks are engaging. So instead of looking at how many folks are not engaging, look at how many folks are engaging, because that's prevention. That means something. So maybe they're not in crisis or distress right now, but what they're getting right now from the service will help prevent a crisis or distress in the future or reduce it. So looking at different metrics, and so being able to have hybrid contracts that include the clinical outcomes, but also include things like engagement milestones, that include things like how are we doing on prevention? I think that's one of the biggest things when we talk about value-based outcomes. We stay on the clinical outcomes. And at least in mental health, they are not linear. Somebody could be doing really well for 2 years and then have a relapse and in their recovery and not do well. And that's less the fault of the intervention, but there could be other things happening. But how that will show up in your outcomes is that the intervention is not working.
Great point, Jessica. Really great. So Jenny, any
I'm happy
Gabrielle?
to add. So it's it's a really great question, Jennifer. Why is this so hard? I think part of this is because you have a group of people who are experimenting with something new. All of them are highly motivated for this to work. They are excited. They get into the idea. They work, and then they start experiencing a lot of barriers, system barriers, right? Because the incentive, they might be remunerated or rewarded not because of the value they are creating for the organization, but based on the dollars they are saving today. And there might be a mismatch. There's also difficulties in roles because, maybe physicians do not understand what you are asking me to do. What do you mean by do I need to identify value? That's not within the traditional role as a physician within their organizations, right? So maybe patients don't know exactly how to fit in all of these. So I think it's hard because we haven't really paid a lot of attention to change management. And I think that having one successful project is amazing, but how to scale that up and replicate that, in a way that will lead to a systemic change, it really takes a lot of thoughts about change management. What is it that motivates people? How can we sustain the change? What type of skills do we need? What type of training do they need? How is best to communicate? What type of organizational structures we need to create for them to have that collaboration? How can we just start looking outside of the organization and outside of this project and start connecting internationally or even regionally so that our ideas will grow further? I mean, there's a lot that we need to think about this. And I think we really haven't spent enough time on that piece. And I think that making that to scale up at the level we want, we really need to pay attention to that change management aspect. Otherwise, it's frustrating to see great projects. And I'm the one who applaud these projects. I really love this team, tremendous courage and tremendous innovation. But how do we grow it further? And I think there's a lot of questions that we can ask on this. Actually, there's some research in Sweden that looked into this as well, looking at value-based healthcare and why is it so hard to do. And one of the recommendations was really looking into how we could sustain, from a change management perspective, how could we sustain that change? And engage in that change better. So I mean that's another area that maybe ICHOM will provide great input in the future. But I think that scaling that up requires a lot of effort in this area.
Jenny, last word on what's making this hard?
Yes, I will go quick. I think actually everybody has a hand in what's making it hard, right? And I say that because from the patient perspective, they potentially have app fatigue and they don't actually necessarily know what they're supposed to be getting out of it. They know that the program they're going to is supposed to help, but how much is it supposed to help? I don't know that we as employers or even companies have been clear on exactly what that is. I don't actually, okay, so then point number 2 is when it comes to the point solution, I don't think that they're incented for outcomes. Most point solutions that have gotten VC funding are incented for either bringing people in or the PEPM. And so outcomes take much longer to prove than a head count or the money that's bringing in. And I think there could be a tweak there. And I think the last piece from the employer side is that, if nothing from the 3 of us or the panel, it's that what outcomes for each program and what it means to different people are variable, right? How you would look at a mental health program to say that you've got good outcomes and how you would look at potentially an MSK program or a diabetes program, not necessarily the same thing. So it's important to get clear on what outcomes you want, but also the definitions. When people talk about value-based healthcare, especially when we talk about medical, we're not talking about necessarily outcomes. We're potentially talking about lowest cost, depending on how it's written. And so I think that, as those and with the work that you guys have been doing, getting those definitions streamlined and really helping people understand, like, here are outcomes and this is what it should look like and here's best practice, which hasn't really been around. That's important to educate the population with regards to, like, this is actually what we're supposed to be buying, right? We're not buying the engagement of the number of hits or the number of calls or how quickly the phone call was picked up as engagement. Like, we're talking about engagement in terms of that interaction with the individual to improve an outcome or a health condition based on best practice.
Dare I say that some of what Jessica was talking about in terms of patient involvement in the design, so we talk a lot at ICHOM about co-creation, and that's really at the heart of the set development, is that we want lived experience to be driving the conversation first and foremost about what are the dimensions of outcomes that are most important. And to Jessica's point, it isn't just clinical, it's also how you're functioning in life. But I think, Jenny, you just said about fatigue and patient communities, like your beneficiaries not really understanding how is engaging with this questionnaire, this app, whatever it is that you're putting in front of them, how is that going to help them? And I think that's something we encounter a lot as a friction point in outcomes measurement writ large, is that we skip over the step of involving patients and families and clinicians upfront in why is this measure going to help you in your daily work? How is it going to help you in navigating your own health condition? How is the information that you can see going to be useful to you and your clinical team in designing what works for your life? We skip over that step because we assume that the digital app or the point solution or whatever phraseology you use is going to solve all problems, and it's going to be this miracle light bulb moment, angels singing. And I think you're all in some way, you're calling out that issue, which is there's a human factor here that is very integral to the change management part of this. And I think I observe that that's one thing we're at risk of now is we have a playbook, that's amazing, but how you implement it matters. How you involve the people, not only that are doing the purchasing, but also that are going to be asked to engage with whatever point solution you're looking at. How the clinicians and everybody involved is going to interpret that data. Those are all parts of the puzzle. And that lives outside of the legality and the language about contracting. It's that human side of this that we can't ignore. They have to be working in concert. So that's just an observation from all the conversations. There are a couple of provocative questions in chat that I wanted to give us an opportunity to talk about. One was around low resource settings. So this could be in low and middle income countries, but we can also talk about settings that just have low resources, cash-strapped rural hospitals or FQHCs, for example, or small dare I say, small nonprofit employers who are trying to get the best bang out of the healthcare dollar that they have. What are the takeaways here for what you can do or what you can incent in a low resource setting? Any thoughts? We're kind of
Well,
switching into
I'd
action
start,
steps.
Jen. Yeah, I mean, I think it's a great question. I'd start first and foremost by we would certainly hope that in those settings, no one wants to recreate the wheel in general, but especially when you're resource constrained, like you don't want to have to recreate mistakes that others have lived through, right? So again, a plug that we would hope that people are leveraging things like our digital health assessments or things like these performance-based contracting toolkits to kind of jump ahead and start from all the learnings that have collectively been surfaced for the past decade plus. I think too, one thing I'll note is that as part of the Digital Health Collaborative, we have about 20 organizations like participating, including ICHOM and others. One of those groups is the Health Foundation, and we've actually given a grant to the Health Foundation to further dig into the topic of what, if anything, really is being leveraged in FQHCs or, again, potentially more marginalized areas as it relates to digital health, and what are the hurdles that are being experienced right now in terms of accessing digital health. solutions, which historically, to Jenny's earlier point, the business models have been set up to really be aimed at more employers for PMPM business models, or potentially to the health plans and health systems. And at times, groups like FQHCs and some others could be left out in terms of access. And these are patients that could tremendously benefit, right, for different solution categories. So I think, first and foremost, it's seeking first to understand or kind of sizing the problem, and then thinking about, well, what are next steps that we could take to create better access points, and even to nudge different business models like accordingly to ensure that that access and additional evidence and outcomes is created and possible.
Good insights. I think there's a lot to do there. Yeah. Gabriela, any thoughts?
I'm happy to. Yeah, I'm happy to add. I mean, I think that these type of solutions are possible in any country, high income, middle income, low income. You're going to choose the solution that is adapted to your needs, to your population, to your budget. But there's always something that you can do. I think it always starts by identifying what is the need, what is the potential digital solutions that you can employ that make sense for that particular subset of population. We have very successful and very positive health solutions deployed in Kenya, for example, deployed in Ghana, for example, that are not necessarily what the US might have or what you might find in Switzerland, but they do work. And they have an impact on patient outcomes for those particular population sets. So in terms of non-communicable diseases, managing hypertension, for example, we have some of these solutions that are built. In fact, if we look at the work of Medtronic Labs, so I really encourage you to look at Medtronic Labs. It's a phenomenal subset of what Medtronic will do. And this is exactly what they do. It's innovation-based, technology-based. The technology is open source, so they work, and it's community-based in different countries. So they have been able to build amazing solutions for India, for Kenya. So this is doable. I don't want people to think that these digital solutions have to be extremely sophisticated and unaffordable, because that's not the case. Even if you start with one or two outcome indicators that you want to improve, rally around those. Look at what are your resources within your own communities, and the resources not only financial, it's also human resources. Also, there are all different resources, and the mix might be different in different communities. But this is not a barrier. There are different ways that you can actually go around this, even if it is working with a spreadsheet, in an Excel, tracking that by hand and using phones. As a maybe one survey that you will send it through the phone and ask people to answer. Some data is better than no data. And if you look at what Medtronic Labs have been able to build, it's really incredible. There are incredible solutions. So, just look beyond your horizon. I don't feel constrained that this is only for rich countries, because that's not the case.
Gabriela, thank you for that. And I hope we can collaborate offline to maybe point our audience to resources or examples, especially if they're in published literature, so that they're shareable, of those kinds of examples, because I think that's really a positive takeaway for this conversation. So turning to another theme among our audience questionnaires, it should surprise no one that I'm about to say this, but AI is disrupting everywhere. So, but at ICHOM, one of our biggest concerns and the reality of the situation is that a lot of the AI, agentic AI, large language models, whatever it is, whatever version we're talking about, is not necessarily trained on outcomes data. Why? Because of all the things we've talked about thus far. The data doesn't necessarily exist yet. We're not asking those questions, especially when we get into the realm of the things Jessica and I at ICHOM talk about frequently, which is it isn't just about the clinical metrics, it's about functioning. So if we're building AI agents, tools on top of data that's largely about bad outcomes, right? The utilization, the claims related data, are we going to be able to leverage AI to help us see, help us mine for outcomes data that can really inform purchasing? So I'd love to know your sense of where are we with AI in this context of how does it help us understand patient outcomes better? And does it have utility for the purchasing contracting conversation? And maybe when prognostication moment, when are we ready to actually leverage AI in this context? Jenny,
I'd
can I
like to
pick on
start
you?
this.
I was
Yes, please.
okay.
Yeah, I think and we've been struggling or with the role of AI, right? Where I do think that AI can really help is helping the patient identify where to go, right? Whether it's app fatigue or navigation or direction of the ecosystem, I think that that can really help. I think that AI can help provide call outs with regards to, hey, these are things to look at. But to your point, it requires more training about, well, what do we really want to look at? What does good outcomes look like? And it's easy enough to, you can direct it to not focus on poor outcomes, but what does a good outcome look like? And then taking that next step of, so then how do I modify this experience so that it could be a good outcome? And I think that's where we have a while to go. The other part of it is that while I do hope it helps employees navigate, at least for my population, I don't discount the fact that some people really need to speak to a human. And my concern is that we put AI in front of people thinking that it's going to solve everything. And what ends up happening is that people then disengage and don't re-engage because they feel like that in itself is a barrier to care. And so that's what I would hate to have happen. And so really the balance of thinking, well, what should that patient experience or what should that employee experience be for whoever the employee is so that they can get the care that they need? And how do we leverage AI to use it appropriately at the right time, getting them the right information, as opposed to that being the new interface that is supposed to solve all of our engagement and access problems.
I would just
I
say, oh, go ahead, Jessica,
Okay,
please.
sorry. Oh, I was
Go
gonna say
ahead.
I agree with Jenny. Folks do need human connection. AI isn't this problem solver. But I do encourage us to think about AI not just on kind of the front door, the front end, but the back end. We do have some of this data, and I think right now a lot of our digital solutions work in silos. And so folks are only using the data that they have, but taking the time and investment to build relationships with healthcare systems and payers, because they are collecting this data, especially if they're already working with larger healthcare systems. I think it would help folks to be able to say, here's what a norm is for my region, right? I've worked in different areas across the US. Taking something like substance use, what that looks like on the East Coast looks very different than what that looks like on the West Coast and what folks are using and how they're engaging. But if I just take general data from the digital solution and then look at my employee population, it's not going to be accurate. But being able to, for the digital solutions, to have data to say, in this population, in this region, this is what we're looking at. Here's what a norm would be, I think would be very useful. And I think many folks, I've even had folks that I've worked with, within the patient population, they are expecting some of that. They are expecting that their data is not always just in such a silo. They're like, well, why can't you just ask this person? They already have this. Why can't you reach out to my doctor and get this history that makes sense? And we don't operate in that way. And so I think if we could figure out a way to improve that, the relationships, and take the time, because rightfully so, you're not just going to call a hospital and get their data that day. That we actually can meaningfully leverage AI to help us to improve outcomes and to do audits and be able to provide information that actually improves care.
I fully agree with that, Jessica. And I think then, it's looking back to of not repeating mistakes in terms of, even as I think about electronic health records back in the day or digital health. And it really speaks to, Jessica, the analog that you said about building the right house based on the problem you're looking to solve and who you're solving the problem for, right? And again, just layering on kind of quote unquote, a buzzword of AI isn't going to fix that problem, but leveraging AI powerfully to be able to further dissect and address the problem that you've been able to really articulate, incredibly powerful, right? And just even a super practical like example. I mean, we've heard from various purchasers that are like, hey, I'm going to leverage AI to even do a cross compare of my existing contract to the performance-based contracting like toolkit that we have, right? Which again, brass tacks, or Jenny, I think it was you who mentioned, related to needing to have some standardization for the data that you're able to collect from various vendors. Again, like we heard a lot of anecdotes of people asking up front to see the exact example or a template of what data that they're going to get back. But then also there's opportunities to kind of leverage AI to do any cross compares of what should be there, right? Or what you were expecting to see before you've inked the contract and it's somewhat too late before it gets contentious.
There's two
Yeah,
thoughts here. Oh, go ahead, Gabriela.
I was gonna just really briefly. I agree completely with the other panelists, and AI is our reality today, and I think there are tremendous power on using AI to understand these contracts and how to draw the contracts and make the engagement. It provides a lot of efficiencies, but also in terms of value-based healthcare. I think that AI is enabling us to customize treatment and get even better outcomes. So it's really very much in line with value-based healthcare. Right now, we have about 6 technologies that are AI-enabled, and the outcomes are better. Are just better. It creates a greater opportunity for customization, personalization, and I think that really will advance the value-based healthcare agenda.
I think across all your answers, something that's very near and dear to my heart at ICHOM, which is standardization, is such a critical conversation. I think there's a lot of churn in this space happening now, in which there's a tendency or a risk of reinventing the wheel, of choosing metrics that are very bespoke and in relation to the individuals involved in the contracting or the vendor that's designing something innovative. And this brings us back to the whole reason why ICHOM exists, which is to give everyone a center line. It's not an only, it's a place to start and a centering, and allows that comparison that I think Meg and Jessica were both talking about, the importance of being able to see where there are regional differences, where there are differences in severity of a condition, for example. And we cannot get to that level of comparison, whether you're talking about hospital to hospital or clinic to clinic, or we're talking across the United States in 2 different states, or if we're talking about multinational. And this is what ICHOM really exists for, is to provide a starting place and a center point where everybody can align. And I think the other message that you all were conveying was that we need to start simply. You can't boil the ocean and try to measure everything all at once. So it's really important in these conversations to be thoughtful, to have the purchaser and the vendor and the patient, the end user, be involved in designing what is that prioritized list of outcomes that can be feasibly and reasonably attached to looking at the value of a particular intervention. I think the last question that I want to pose to you, because as ever, time grows short, we have a number of really thoughtful and complex questions in the chat. To those of you that have taken the time to write them, I assure you we will do our best with our speakers to give you some thoughtful responses, links to resources and things like that. But I wanted to end by asking each of you to reflect on, just you're speaking to your community, right? So Jessica, you're speaking to the patient community writ large, whether it's just mental health or advocates in general. What's an action that you feel that your stakeholder community can do today, tomorrow, that will really propel some of the themes that we're talking about in the right direction? So I am going to work backwards. Jessica, can I start with you to reflect on what's an action step that you at MHA or you would challenge others in your stakeholder community to act to propel this conversation about embedding patient-centered outcomes in performance-based contracting?
I think I call them Monday morning action items. I would recommend to both vendors of digital health and employers who are working with the vendors to have patient advisory councils. I have led these even at some of the companies that I have worked at, and you would be surprised often the things that may be missed that are actually very helpful just by having a conversation. This doesn't have to be something that feels like a very heavy load. It could be a group that only meets once a quarter or, twice a year, but actually having a conversation with them and getting feedback, you learn a lot of information about why folks may not engage, what might be a barrier that might not even be a part of your perspective. And I think it helps on both sides to help to reach a consensus on what goes into a value-based contract.
Thanks. Can I go to Jenny next?
Sure. For my employer-based coalition, I would just say start wherever it makes sense, something that's meaningful to you, right? Pick a program that you personally feel like you would like to improve and start having conversations, whether it's with other employers or with any of the organizations, right? ICHOM and PHTI, and just start small. And there are also organizations that have PGs and value-based contracting with outcomes in there. And so maybe it's just a place to start, but I think that getting involved in the conversation, regardless of whether or not you think your culture, your leadership is going to go for it, or whether or not you think you can actually pull it off, don't worry about it, because this will take care of itself. This conversation will take care of, if you have this conversation, it will take care of those two pieces so that you don't have to worry about it. And at the end of the day, it'll be a win, not only for the employees, but for the business and for us as leaders who are trying to change the direction of how we have these conversations with industry.
Fabulous. Gabriela.
I might get in trouble with Nike for this, but I would say just do it, right? You have to start somewhere and just do it. There are many examples of value-based healthcare projects and value-based contracts, in obesity, heart failure, heart rhythm, diabetes. There are many, cancer, different types of diagnostics. Even in how we manage operating rooms right now, there are possibilities to establish value-based contracts for any of these. So there are many clinical areas, and there are many examples. Just get interested. Look for these positive experiences. Reach out to people who have done it. Inform yourself, and just have the courage to start somewhere. It's just sometimes it feels overwhelming when it's something new that you've never done it. It's going to test the limits, and that's the only challenge of this, right? Like, people have their everyday jobs, they won't stop, right? So these jobs have to be done. So this is something in addition to. So but in understanding all of these, just take a leap of faith and do it, because I think you'll discover that you'll learn a lot in that process, and those skills can only grow from that point on.
Fabulous. Meg, last word, and then I get to close us out.
Really just plus one to what everyone else has said, and to please, we hope, leverage our freely available reports and things like our playbook and toolkit, so that, again, you can kind of make sure that you're learning what others have like to date, and then take that and utilize it with discussions with your vendors and partners. So thank you.
Perfect. I want to say, first of all, and foremost, thank you for this lovely conversation. I'm just in awe of your advocacy and your expertise in this area, and thanks for the wisdom that you shared with our audience today. I would love to keep talking about this. I will pile on to just say, simply start, use ICHOM as a resource, keep patients involved, to echo what Jessica said. And I think most importantly, and something that ties everything together, which is share what you're learning. PHTI is a platform to share where there's successes. ICHOM also is a place where you can share what's working. How are you pivoting your contracting? What is the outcomes that you're able to achieve by doing this performance-based contracting? And I will tell you a specific way you can bring your impact to ICHOM, and that is at our conference, which will happen at the end of this year in early December in Montreal. This is a place where everybody who's working in this community all the stakeholders represented here, as well as others in the clinical level on a global scale, come together to talk about what's working, how are we making this work. There will be sessions on performance-based contracting, on outcomes measurement, on patient involvement and leadership in defining outcomes that matter. This is the place for you to come and learn more if you found this webinar stimulating, exciting. So thank you for your attention. As I said, we will do our best to answer any questions we didn't get to today in a different format. This has been recorded and will be up on our YouTube site. And once again, thank you to all my panelists, as well as to PHTI for helping us to make this happen. We really appreciate your time, and we hope you have a wonderful rest of your day wherever you are. Thank you.
Thank you.
Thank you.